Okay, thank you so much, colleagues. I'm pleased to deliver a presentation on One Health service provision experience in the Horn of Africa, the case of One Health for HEAL. Next slide, please. So let's start with the context. As you well know, the lion's share of the population in the Horn of Africa depends on livestock production as a predominant means of livelihood. But livestock production as a lead source of livelihood is becoming under pressure due to high vulnerability of the greater Horn of Africa, including climate change, drought, conflict, and so on. As a result, this area is known as for high mobility of the pastoral and agro-pastoral communities looking for scarce resources, including pasture and water. Furthermore, this is exacerbated by poor access of the pastoral communities to basic services, including human health, animal health, and environmental health services. Next slide, please. So it's within this context that HEAL is designed and implemented in the Horn of Africa, in Somalia, Kenya, and Ethiopia. And the goal of the HEAL program is to improve the well-being and resilience of the vulnerable pastoral communities in the Horn of Africa. So we are working to achieve this goal by improving access to quality human health, animal health, and also promoting sustainable natural resource management. And we're working to achieve this mission by engaging communities in defining sustainable, demand-driven, and need-based One Health units. One Health units are equivalent to facilities that provide integrated service, animal health, human health, and environmental health service at the doorsteps of the pastoral and agro-pastoral communities. The second one is by implementing context-specific and cost-effective service delivery models. And the third one is by providing evidence, not only to the government, policymakers, but also to investors on One Health units as a solution to the service provision in the Horn of Africa. Next slide, please. So we're implementing a HEAL program. It's a 13-year-and-a-half program, of which we have passed through the inception phase of 18 months, and we're in the first phase, which we call pilot phase. And we have completed 3 years, and now we're on the 4th year. And after this, we're expecting 8 years of implementation phase from SCDC. The budget for this first phase is about 9.8 million CHF, of which 50% is financed by our generous donor SCDC, and the remaining by other financiers, including EU and BioVision. We're implementing HEAL in 3 countries, Somalia, Kenya, and Ethiopia. In Somalia, we're implementing in Gedo region, notably in 2 districts known as Baladhawa or Bulahawa and Gollo. In Kenya, we're implementing in 2 counties, namely Isiolo and Marsabit. And in Ethiopia, we're implementing in 2 regional states, namely Oromia and Somali regional states, completely in 4 districts, Filtu, Moyale of Somali, Moyale of Oromia, and Miyo districts. Next slide, please. So HEAL has several salient features. The first one is we're implementing this program in a consortium of 3 organizations, namely VSF Swiss, specializing in animal health, and it's also the lead agency for HEAL, AMREF, specializing in human health, and ILRI, specializing in environmental health and also research component. The second one is we are working in strategic partnership with government partners. Imagine, we are not creating a parallel structure. Rather, we are using the existing structure to expedite and facilitate the provision of integrated One Health service. That means animal health, human health, and environmental health at the doorsteps of the pastoral and agro-pastoral communities. To this end, we are working in strategic partnership with the One Health task force at district level or sub-county level, One Health units at the grassroots levels, and the frontline service providers. The third one is we are implementing flexible and scalable model. We'll come into it in the next slide. We are implementing 3 models. mobile One Health unit, static, and mixed one. Please, to the previous slide, please. Hi, colleagues. The previous slide, please. The previous one. The previous one. And also the previous one step. Okay. Next. Yes, we are also enjoying strong commitment of the donor. Please go to the previous slide. Strong commitment and long-term commitment of our donor, and this has enabled us to think about outcome, impact level indicators, and sustainability. As you well know, so many projects are not enjoying such long duration of a project. The other one is we are also enjoying strong commitment of community engagement, and we are applying a bottom-up approach through a local structure known as multi-stakeholder innovative platform. The sixth peculiar feature of HEAL is its alignment with policies and strategies of key actors, including policies, One Health strategies, health sector development policies of Somalia, Kenya, and Ethiopia. HEAL also aligns with policy strategies of multinational or multilateral organizations, including the African CDC, the UN, and the European Union. Next slide, please. So we have about 4 pillars. The first one is we are establishing One Health units. These are new service delivery models which promote integration of human, animal, and environmental health services as the doorsteps of the pastoral communities. By doing so, we have 3 models. Mobile One Health units in which service providers move along livestock routes together according to agreed schedule. We have a static One Health unit in which service providers work from a given or a common facility. And we have also a mixed One Health unit in which part of the community gets service from a common facility and part of the community receives outreach service. So in these One Health units, we are promoting multi-sectoral and integrated approach. So we have human health professional, animal health professionals, and environmental health professionals. With human health, we have health officers, registered nurses, and health extension workers or community health workers. With animal health, we have community animal health workers known as cows and animal health technicians. With the environmental health, we have natural resource management experts, development agents, and some others. The next slide, please. The second pillar is multi-stakeholder innovative platform. This is a local structure which draws its members from the local community to promote local engagement, participation of the communities in all aspects of the service provision. So it draws its members from religious leaders, local leaders, service providers, traditional birth attendants, representatives of women, representatives of youth, and so on. So these MSIPs play pivotal role in the design, implementation, and monitoring of One Health units. They convene at least once monthly so that they discuss contemporary issues that matter most to the pastoral and agropastoral communities. The third pillar is One Health Task Force, which draws its members from sector offices, including the health department, the livestock department, veterinary service, the natural resource management department, and it's most often led by the district administrator. So this One Health Task Force is responsible for so many things, including recruitment and placement of frontline service providers, providing supplies, supporting frontline service providers, and so on. The next slide, please. So this is the way it works. We have a human health service, which includes antenatal care, postnatal care, family planning, growth monitoring, nutrition screening, medical consultation. In animal health sector, we have disease surveillance, we provide vaccination service, we provide curative service, animal husbandry, and animal products management. With rangeland management, we develop participatory rangeland management plans so as to improve the grazing management of the pastoral communities. We also engage in rangeland restoration and plastic removal. We also provide integrated services, including waste management, education and awareness creation, outbreak management, and capacity and capability building. Next slide, please. The third pillar is sustainability. No matter how, projects phase out sometime because they are temporary endeavors. But the outcomes, the outputs that this project generate need to continue benefiting the community. So HEAL places high value for sustainability, and we are working to ensure this through three pillars. The first one is social equity. As I mentioned earlier, provision of One Health service is user-defined. That means the multi-stakeholder innovative platform, the One Health task force are engaged in the design, implementation, and monitoring and evaluation of the One Health service provision. We are providing capacity and capability building. All these things will contribute towards social equity. So if the community owns, they will show sense of ownership, sense of belongingness, and without doubt, this will lead to sustainability. The other pillar is economic viability. The three sectors practice joint planning exercise. They move together. They provide integrated service at the doorsteps of the pastoral communities, the human health, animal health, and environmental health service at one stroke. Furthermore, service provision is capacitated or powered by health insurance. There are some villages in which the community-based health insurance reached 100%. So this is a good example of ensuring sustainable provision of One Health at the doorsteps of the pastoral communities. The other thing is environment is an integral component of HEAL. That means if there is good management, proper management of the rangeland will provide pasture on sustainable basis, and this will support the livelihood of our pastoral communities. Next slide, please. So to take you to the key achievements, we humbly start year one with interventions in 18 sites, and we established about 18 MSIPs. There, we further scaled up to 27 sites, and we established 27 MSIPs. And in year three, we also expanded into 11 more sites, and now we are managing 38 sites in the three countries, Somalia, Kenya, and Ethiopia. With this, we have 725 MSIP members, of which 38% are women. So we are also encouraging the gender balance, encouraging the participation, engagement of women in the provision of One Health service. That matters most to the community. The next slide, please. So the other achievement is in terms of establishments. We have established 16 One Health units, including static One Health units, mobile and mixed. We have 38 MSIPs, and we have established 8 One Health task forces at district level. For instance, in Somalia, we have 2 One Health task forces at Dollo and Bulahawa. We are also working hard on system strengthening, and so far we have managed to develop standard One Health training modules. We have also developed One Health facilitators guide, and we have also developed One Health standard operating procedures so that the integrated service provided in the different sites is a standard one. We have provided training on this, and it's going on very well. We are also doing great in terms of building the capacity and capability of One Health service providers. With this, we have so far managed to train 146 One Health service providers, 744 representatives of communities, and 312 government officials. The next slide, please. So with the provision of an integrated service, we have managed to reach so many communities with an integrated service. For instance, with the human health service, we have managed to reach about 113,000 people with awareness creation, about 36,000 with vaccination service, about 90,000 with curative or treatment service, about 9,000 with antenatal care to pregnant women, and about 57,000 people received nutrition screening. Especially, we intensified nutrition screening in the last 2 years, given the severity of the drought in which the Horn of Africa was ill. With regard to animal health service, we have provided vaccination service to over 1 million animals in the Horn of Africa. We have also provided about 500,000 animals with treatment service. And this service has benefited a total of about 77,000 households in the Horn of Africa. With regard to environmental health service, we have provided training to customary institutions, which we call rangeland management customary institutions. We are working to strengthen the capacity and capability of these customary institutions. We have also produced digitized maps for rangeland in the Horn of Africa, and we have drafted rangeland management plan, and it will be finalized soon for implementation. The next slide, please. Learning is at the heart of HEAL. So we publish success stories, we publish photo books, and we have a website which you can access. And in this website, we have updated news and we have resources, assessments, anthropological studies, progress reports, success stories, photo books, and so on. We have also we also publish our work on magazines. We also disseminate these learnings using different venues, including workshops, meetings, conferences, and many other venues. This photo are just a sample of it. The first one is we were sharing our participatory rangeland management experience to IGAD countries. The second one is we were sharing our One Health experience using the 36th annual conference of the Ethiopia Veterinary Association. And the third picture is we were using expos, pastoralist expos in the east of Africa, which was held at the beginning of February, pastoralism, the East African mosaic. So we managed to disseminate the so far learning in these symposiums. Next slide, please. Accountability is also at the heart of HEAL. So we have developed an exit interview tool, which has some 10 key questions, including access, level of satisfaction, proximity, and waiting period. With this, we were managed to reach so many people with this exit interview. So about 27% of the population responded that it was their first access. Otherwise, the remaining 73% of the interviewed people have accessed at least twice or 3 times or several times. We have also tracked the level of satisfaction among our clients, and they reported that 82% of the respondents reported that they are very much satisfied with the integrated One Health service provision in the Horn of Africa. With regard to proximity, 97% of respondents reported that they are receiving this service at the doorsteps of their village. With regard to waiting period, about 57% of respondents reported that they are getting the One Health service, integrated One Health service immediately. And about 41% reported that they get the service in less than an hour period. Next slide, please. The last slide is about challenges and aspirations. We have encountered about 4 major challenges while working in the Horn of Africa. The first one was urgent and emerging needs. This specifically dwells on the severe drought, the extended drought the Horn of Africa encountered in the last 3 years. As you well know, we have missed about 5 rainy seasons. And this has put the life and livelihood of the pastoral community into jeopardy. And we have to look for funding so as to implement drought response activities. So fortunately, we managed to mobilize resources of about 1.6 million CHF, of which 50% was from SCDC and the remaining from co-funding. So we have tried our level best to address the effect of the drought. The second challenge was insufficient local technical resource. The number of frontline service providers available in the field does not match with the demand for the service. So we created several discussions with the One Health Task Force members at district level, and now we are in a good shape. They have assigned frontline service providers that provide integrated service at the villages of the pastoral communities. The other thing was replenishment of drugs in the One Health units. As you well know, this extended drought has resulted to massive days of livestock. So we have to intensify One Health service and One Health outreach sites. So we have increased the frequency, and that has resulted to the end of or shortage of drugs. So we have approached different donors, including WHO. So they provided us with medicines, drugs, equipments, and other facilities, and we are trying to cope up. The other one is co-funding. SCDC is financing 50% of our program, and the remaining 50% is expected to be covered from co-funding. In the first 2 years, this was a challenge because, as you well know, the funding landscape shifted dramatically to contemporary issues, including the war in Ukraine. So that time was a challenge for us. But as the drought in the Horn of Africa started to receive attention of big donors, the funding landscape improved gradually, and we have managed to address the issue of co-funding, and now we are in a good shape. Our aspiration is to see governments consider One Health units as a solution to the health service delivery in pastoral and agro-pastoral communities in the Horn of Africa. And our future needs are basically 2. The first one is building evidence base. That is, to what extent is One Health service provision cost effective? This was amongst the activities that we planned in the last 3 years, but we couldn't do that because of the severe and extended drought, which put the livelihood of the pastoral communities at jeopardy. So, leave alone paying or sharing cost for service delivery, they are not in a position to cover their food or basic necessity costs. So that was pushed to the next phase of the program. Our second need is further scaling up of One Health service. To this end, we are doing very great. The One Health service, that's the integrated One Health service provision, is highly accepted by the community, and we got a very big buy-in from governments of Somalia, Kenya, and Ethiopia. But one of the bottlenecks that hindered scaling up of this One Health service to other areas was limitation of the budget and alignment of the budget to curb the bad effects of the drought. So the governments in Kenya, Somalia, and Ethiopia shifted most of their budget towards addressing the bad effects of the drought. So they did run out of budget for scaling up One Health service in the HEAL catchment. So in our next phase of the program, this is amongst the forefront agendas that will be implemented. So I'm through my presentation. If you have questions, comments, or suggestions, you are most welcome. And we look forward to work with you all. Thank you so much, colleagues.